Okay, thank you, everyone. You can let me know. I think you can see my slides here. So I'm going to talk on a very specific topic, which is, although it's a smaller topic than the sort of cross-cutting talks you've heard earlier today, it's a critical topic for so many people in the desmoid community, and that's the issue of pregnancy and desmoid tumors. And let's see here. Okay. So just to give you a little bit of background about this, I'm not going to reiterate what Dr. Wilke's already stated, but the term desmoid was first coined in 1838 by Johannes Müller, and John McFarlane in 1832, previously, before the term desmoid was used, had described an organized sarcomatous tumor between the layers of the abdominal muscles in women who had children. So this is probably the first real description of what we now know as a desmoid tumor arising in or after pregnancy. Desmoids are often diagnosed in young women during or after pregnancy. This raises concern that about potential progression during the current pregnancy if it's diagnosed during the course of pregnancy, or recurrence with a subsequent one. And this raises a lot of questions. It's also led to a lot of misinformation based on lack of data about family planning. And there are limited existing data to guide women about desmoids and their treating clinicians regarding future pregnancies. So we put together this study, which we published in 2014. It was led by Marco Fiori in Milan, and it combined data from Milan, from Via Juif in France, Toronto, and our institution here in Boston. And basically, we combined our experience of women who had desmoids identified during pregnancy, or had desmoids and then got pregnant, or had desmoids that were either in place or removed, and tried to understand some natural history. So the objectives of the study was to focus on three specific groups: those who had desmoids identified during or right after being pregnant, those that had desmoids in place that had arisen either sporadically or in this context initially of FAP, who later got pregnant, and those who had had desmoids removed in the past and who later got pregnant. We wanted to identify risk of progression with watchful waiting, a risk of recurrence after resection, and risk of recurrence during a subsequent pregnancy. These are the four institutions which combined data, and we included women as described there. We ultimately decided to exclude the FAP subset of patients just because we did not have enough individuals to really make much of an analysis. We also excluded those with infantile fibromatosis and plantar and palmar fibromatosis. And so we had a total of 92 patients, as you see here. The first subset, those that included women with pregnancy-associated desmoids, included 44 women. Initially, and now one thing to keep in mind is that a lot of these patients that were treated at a time when most of our management was focused on, well, there was a lot more surgery involved in initial management. And I think that we're actually planning on updating our series. Dr. Fiori is going to lead that effort again. And we've discussed this in the last few weeks. And I suspect that in that group, we'll see a lot more individuals who are managed without surgery compared to our initial study. But in this first group of 44 women, we had 15 that were treated with surgery, 2 that were treated with various medical therapies that Dr. Wilke described, and 27 that were treated without any surgery or any intervention. 2 of those women that underwent surgery had surgery during pregnancy, and 13 had it postpartum. During the course of pregnancy or immediately afterwards in their postpartum period, those that were treated initially with watchful waiting progressed. 17 progressed, 10 did not progress. And of those that progressed, those that did not progress, 10 were still managed with the watchful waiting approach, never required any intervention. Of those that did progress, 6 went on to surgery, 6 went on to medical management, and 5 were still managed with watchful waiting. So when we look at our entire group, of 44 women, 21 ended up having surgery. That number would probably be less now. 8 were treated with medical management, and I'm curious to see what's going to happen in our updated series with this subset. and 15 were able to avoid any sort of intervention whatsoever. So a third did not require any intervention. And this is just the percentages, which I'll just sort of skip through in the interest of time. Now, this is a case example that from the Milan cohort, which still sticks with me. And this was a young woman who was diagnosed with a 3-centimeter abdominal desmoid during her first pregnancy. Afterwards, she was treated with watchful waiting, had no growth postpartum, then got pregnant again. The tumor grew. After postpartum, the tumor stopped growing. And so she was again watched with, or just managed non-operatively and without any medical management. She had a third child, and again, the tumor grew. And then she ultimately underwent surgery postpartum because the tumor had gotten to the point where it was causing discomfort. So then what about people who've had women who've had a desmoid that's been removed and then get pregnant? We had 29 women who fit that description, 19 primary desmoid presentations, 10 recurrent. And so these are unresected desmoids. 16 progressed during pregnancy, 13 did not progress. Of those that progressed, 6 underwent surgery, 2 were treated medically, and 8 were watched. And thus 55% of women with unresected desmoids progressed during pregnancy. And that's something to keep in mind. And this number sort of, again, is one that sticks with me when I advise women with a desmoid who are considering getting pregnant. What's interesting is that those that were watched with or managed with watchful waiting did not progress further to a point that they required intervention. Again, that was a selection bias there, likely in terms of who we pick for watchful waiting. And then the final cohort is the group that had previously resected desmoids who then got pregnant, 19 women. 4 progressed during pregnancy and 15 did not. So 2 of those required surgery, 1 was treated medically, and 1 was treated with watchful waiting. So about 21% of 19, against this percentage of a small number of women that had prior or previously resected desmoids developed recurrence or progression of potentially microscopic disease during pregnancy. So to conclude, I think that what this tells us, and Dr. Wilkie, I think this was her take-home point number 7, mentioned that having a desmoid does not preclude getting pregnant or getting pregnant again. In the past, I think was something I learned from when I first gave this talk at the same symposium 6 years ago, was that many women had been told they should never they should avoid getting pregnant. And we clearly have no evidence to support that recommendation. Women should also not be advised to routinely have an abortion if they're pregnant. There are individual circumstances that may impact the health of the mother or the child that may supersede these recommendations, but desmoids are not a contraindication to having children. Desmoids arising during pregnancy or already present before pregnancy may grow, but over half of patients can avoid an operation. Some may need medical management, but many do not need any intervention whatsoever. And those undergoing surgery can still recur, although the recurrence rate seems to be lower than for other sporadic desmoid tumors. And desmoids resected during pregnancy recur infrequently, so the majority of women still do not recur, but 21% do. Thank you.
Could I ask one question that has been appearing? What is the impact, if any, of the location of the desmoid tumor on all of this? All of these women, were they intra-abdominal? If they have a tumor in the arm rather than in the intra-abdominal area, how does all of this get impacted?
Yeah, this is an excellent question. And in fact, I think one of the questions that was submitted before the meeting addresses this as well. So most of the women that have pregnancy that arises or have desmoids that arise during pregnancy seem to have abdominal wall desmoids, often rectus sheath. Unclear why, potentially some stretching of the muscles that leads to essentially some kind of scarring reaction. We don't really have the details. Those appear to have beta-catenin mutations, but we are, now that we're sequencing those particular tumors, we're finding some other mutations, which I hope we'll have more data on soon. The concern, of course, is for women who have a mesenteric desmoid, because if that grows, that's going to potentially impinge on the growing gravid uterus. And that could be a reason to either have surgery or talk to the gynecologist about management of the pregnancy. In our series of 92 women, and again, this is just a small subset of patients, the only patient that had to have a change in the management of her pregnancy because of the desmoid was one who had a desmoid within the vaginal canal. So she could not have a natural childbirth. She did have to have a cesarean section. But I think the biggest concern is for women who have mesenteric desmoids that could affect or impact the course of pregnancy. Oh, well, there's one other point, and I took out this slide in the interest of time, which is if I do counsel women who've had, if they're going to have surgery for an abdominal wall desmoid and plan on getting pregnant again, that they need to work, their surgeon should work very closely with a plastic surgeon. And so whenever I operate on a patient who wants to get pregnant again, I have the plastic surgeon come in and do the reconstruction. And the reason is that traditionally for the abdominal wall defect that needs to be closed, so there's basically a gap in the muscle, and to bridge that gap so you don't get a hernia, we have to put in usually a piece of mesh. The typical mesh that we use for most hernias is really has no real elastic property. It doesn't stretch. There are other types of biologic meshes or flaps that can be brought into that can stretch better, particularly if the desmoid arose along the lower part of the abdominal wall.